All right, my topic is the treatment of oligometastatic prostate cancer. And Dr. Sylvester just talked to us about treating the prostate primary in this context, so I will talk less about that and talk more about systemic therapy and radiation to the metastasis. These are my disclosures. None of them are particularly relevant to this talk. So, where we're going for the next 15 minutes or so is we'll talk about the definition of oligometastatic prostate cancer, systemic therapy, radiation to the metastasis, and then I'll give you a couple take-home messages. So this slide is courtesy of Dr. O, and it's acknowledging a publication from almost 30 years ago, which basically is bringing attention to this state of metastatic prostate cancer with very limited number of metastases. Now, of course, up until recently, metastases were defined by what we call conventional imaging, bone scans and CAT scans. And I think we probably all know patients or even friends and relatives who have had a cancer, maybe a non-prostate cancer, that has metastasized, but they've been cured. I have a friend, a colleague who had metastatic colon cancer to the liver, and remarkably, that was 10 years ago and is in complete remission. So non-prostate cancers, other cancers, like for instance, colon cancer, have been proven to be curable in this oligometastatic state. And I would say in prostate cancer, we're in the midst of figuring out how to cure our patients with oligometastatic prostate cancer. Is it possible, and how is it best to do that? What is the definition? This is a summary of table of a variety of different definitions that have been used in different studies, most of them fairly small studies, where people have used the definition from 1 to 5 or fewer metastases. Again, based on conventional imaging or earlier stage PET imaging, such as choline PET. I don't think there's a one right answer, but I think it's important for you to understand that there may be differences in outcomes based on the number of lesions and the site of lesions. So this is one analysis that shows that if you have low volume oligometastatic disease, defined as fewer than 3 lesions, so 1 or 2, your outcome in terms of the time to developing castration resistance was much better than if you had higher volume, in this situation 3, 4, or 5 metastases. And similarly, the site of the oligometastatic disease makes a difference as well. So this shows lymph nodes versus bone versus visceral disease, or both bone and visceral. And patients do much better over time prior to developing castration resistance or other late stage events if they have simply lymph node disease. So these are important data to keep in mind when you're thinking of your patient in the clinic and the different choices you have for treating them. So I am not going to spend a lot of time on this, but as we've talked about for the last day and a half, PET imaging is revolutionizing the field of prostate cancer. I think Dr. Crawford said that it's one of the biggest advances that he's seen in his career. In 2016, fluciclovine PET came into practice, and between 16 and about 21, we were using fluciclovine PET. We're not using them anymore at the Dana-Farber. We're primarily using PSMA PET. And all of our data and how to treat patients with metastatic prostate cancer is based on conventional imaging. So to some extent, our data over the next 10 years is going to be refined as we use PSMA PET to define our patients. And this, again, you've seen these pictures all through the last day and a half, but they really are quite amazing and makes us realize for, however, a lot of us in the room, our careers have been, 20, 30 years, is like, we really had no idea how much disease our patients had. And the PSMA PET scans, similar to this one, are quite frightening, actually. And I hesitate, patients a lot of times now in the clinic, you can bring up their images right on the screen in front of you and share them with them. And I definitely hesitate to bring up these type of images with the patients because I'm not sure it's psychologically therapeutic, but it is what it is. And this is the day and age we're at. So systemic therapy, I'm going to start with that for oligometastatic prostate cancer. So it's metastatic prostate cancer, even though it's few metastasis. And the NCCN guidelines, based on large randomized phase 3 trials, states that the standard of care is androgen deprivation therapy plus an androgen receptor pathway inhibitor. We call them ARPIs, which include abiraterone, enzalutamide, apalutamide, and now darolutamide. And for patients, I'm going to show you some tables where we look at low volume versus high volume, and then we're starting to use the term synchronous versus metachronous when we're thinking of metastatic prostate cancer. Synchronous meaning that when you're diagnosed with prostate cancer that's metastatic, you walk in the door with metastatic prostate cancer. The primary and the metastasis are discovered synchronously. Versus metachronously is when you have a patient who's initially diagnosed and treated for localized disease, and then at some point over the ensuing years, they develop metastasis. And that's metachronous metastatic prostate cancer, and I will show you has, in general, a more indolent course. So this is a busy slide, but shown on the left are all the phase 3 trials evaluating the ARPIs in metastatic hormone-sensitive prostate cancer with the abiraterone trials at the top, followed by enzalutamide and apalutamide trials, and I added the Ariston's trial on the bottom, although it's not darolutamide alone, it's darolutamide and docetaxel. And you can see, based on volume of disease, that these drugs all have efficacy, and across the trial, the hazard ratios are remarkably similar for trials that were done over a range of years and different platforms. So when a patient asks you, which one of these drugs should I choose, there really isn't an efficacy metric that you can decide which ARPI to treat the patient with. We really think of the drugs in terms of the potential for toxicity and the patient's baseline status in terms of concomitant medical issues to choose one drug over another. For instance, if someone has some underlying liver disease, you might not choose abiraterone, which can have some liver toxicity. If someone has an underlying seizure disorder, you might not choose a drug like enzalutamide or apalutamide, which can put people at increased risk for seizures, and so forth. But it's important to know your patient well from a medical standpoint, and then choose which one of these drugs in the context of metastatic prostate cancer you think is best for them. So this is, as I mentioned, a good framework to have in your mind to think about the patient in front of you with metastatic prostate cancer. Do they have, let's just say, 4 or fewer metastases? Again, these data were based on conventional imaging. And are they metachronous versus synchronous? And then as you're thinking about this, you're thinking about the prognosis of the patient in general. And you can see on the left the sort of average overall survival just in the context of ADT alone, starting with the best case scenario and moving to the worst case scenario. So the patients who have the best prognosis of those who present with metachronous low volume disease. ADT alone, about an 8-year plus or minus survival. We generally treat those patients with an ARPI, choice up to the physician and patient as noted, and we'll consider adding on SBRT to the limited metastasis. Going all the way to the bottom, the patients with the poorest prognosis of those who have synchronous, large volume, high volume metastatic disease with or without visceral metastasis. And you can see those patients in general do very poorly with about a 3-year overall survival. Those patients, Dr. Bryce is going to talk in more detail about choosing doublet versus triplet therapy, but those patients in general should be offered triplet therapy, and always be thinking about clinical trials because their outcomes are not good in the long term. And then in the middle, metachronous high volume disease is not very common. They're always the lowest number of patients in any trials, primarily because we follow our patients closely and usually pick up their metastasis in that context before it's high volume. And then the other group there in the middle, which is synchronous low volume, which is seen quite a bit. And in those patients, as Dr. Sylvester mentioned in the last talk, in addition to the systemic therapy, radiation to the prostate is considered standard of care. All right, so this is a really interesting topic. We kind of have to think outside the box a little bit, but I think we've been doing this for a while, and I want to share the data with you. So it's SBRT to the metastasis without systemic therapy. And why this is thinking outside the box a bit is that I just showed you that all of the ARPIs have overall survival benefit in the context of metastatic prostate cancer. So if you're going to treat a patient, treat their metastasis without systemic therapy, you have to, sort of share with them that you're not treating with drugs that have been shown to improve overall survival, and really drill down with them, which I'm going to show you in the next couple of slides, what they're potentially gaining from this approach. So the first trial that looked at this, which was really just a sort of a pilot phase 1 proof of principle, proof of concept trial, was this PopStar trial. And these trials, they have the best names. Kudos to the radoncs that came up with the names. So this was a small number of patients, 33, SBRT, single fraction, and basically what this is showing is there was PSA response, and that the 2-year freedom from ADT, starting ADT, which I think is probably the best endpoint from these 3 trials that I'm going to show you, and they're all fairly consistent, was about 48%. So small trials starting us going, at least in the prostate cancer world, into thinking about doing this. The next trial was the STOMP trial, which was a randomized trial for patients with 3 or fewer metastases, and they were randomly assigned to SBRT or to surveillance. So again, small trial, 62 patients, primary endpoint, ADT-free survival, published in JCO in 2018. And these are some data from that trial. On the left is PSA response. So again, it's proof of principle when the PSA is going down. And the other graph there is biochemical recurrence-free survival. So this is not radiographic recurrence-free survival, but PSA, so a less sort of serious endpoint, if you will, but positive. So randomized, small, positive on showing response and delaying PSA progression, 62 patients. And this was the primary endpoint, and there was an increased time to starting ADT in these patients. And when I think about applying this type of treatment for one of my patients, recommending it, this is the data that I share with them. Oops, this went back on its own. And, so it was 13 versus 21 month on that of delaying starting hormone therapy. And we all, we know, and we've talked about the side effects of hormone therapy. So as a medical oncologist and someone who's thinking about our patients' complete medical profile from weight and conditioning and diabetes and hypertension, especially other cardiovascular risk factors, delaying starting ADT, I think, is a very important endpoint, although again, it has to be balanced against what we know is an overall survival benefit for the drugs that cause those side effects. This is the third trial, the Oriole trial, which was similar. It was a 2-to-1 randomization to observation or SBRT to the Mets, and 3 or fewer Mets, the same as the last trial. And this is progression-free survival. It's a composite endpoint. It's PSA as well as radiographic progression, and in favor of the SBRT to the 3 or fewer metastases. Again, a very small trial, unfortunately, 54 patients. And they did something kind of unique in this trial, which is they did PSMA PET scans, but the PET scans weren't part of the outcome measures, and they weren't shared with the treating radiation oncologists. And, until after the trial was over, they were analyzed. And you can see that yellow line there on the right. Those are the patients in whom there were metastases on the PET scan that were not treated with irradiation. And you can see you're not buying your patients anything, I would argue, if you're not treating all the metastases. So if you're going to consider this type of approach, this is the data we have. 3 or fewer Mets. What do we do with the guys with 4 or 5? Or I was part of a trial in which we defined oligometastatic disease as long as the number of Mets could fit into 3 radiation treatment portals, they were considered oligometastatic. But these trials that you will hear, quoted a lot, STOMP and Oriole, conventional imaging, 3 or fewer Mets, backed into it with some PET data that you need to treat all the Mets. And now the standard of care would be to do a PET scan prior to considering this type of therapy. And this is a newer publication that I found in the context of making this talk, which I thought was really kind of helpful. And we've talked a lot in the last day and a half about risk stratification and not treating everyone the same way. And so this group of investigators found all the patients that they could. That's what that consort diagram on the right is showing you from the STOMP and Oriole trial, who had tissue available and that the tissue went through to sequencing. And they defined a mutational signature. So this is somatic sequencing, nothing special, for ATM, BRCA1 or 2 mutations, RB mutations, or P53 mutations. And what they showed is that if you had any of these mutations, which is the blue line on these curves, your progression-free survival with this sort of, radiation to the limited number of metastases in these 2 trials was very ineffective. In fact, if you had no mutations, it was 13.5 months median PFS versus 2.8 months, so very short. So if you're thinking about this approach for the patient in the clinic, I would argue that, do I have a conclusion slide? Yes. I would argue that, it should be patients with a very limited number of Mets, 1, 2, 3, patients with nodal disease especially, or limited bone disease but not visceral disease will do better. And probably we're not typically doing somatic sequencing on these patients, but you have prostate biopsy and you have prostatectomy tissue available in a lot of these patients, and maybe it would make sense to not waste time or energy or resources in applying this type of treatment in patients who really need more aggressive systemic therapy. This is the part about treating the prostate, which Dr. Sylvester nicely handled. So I am not going to review that again with you, except to say that I don't think he showed this. He might have. There was an update that was published in 2022 that showed that this holds up. It should be standard of care to treat the prostate in patients who have low volume metastatic disease, primarily based on the STAMPEDE trial. And less sure of the benefit in high volume, although it has been shown to reduce urologic complications. All right. So finally, in conclusion, oligometastatic prostate cancer is frequently encountered in our clinical practice. Next generation PET imaging is altering the definition of oligometastatic disease as more sites of disease are identified. Androgen deprivation therapy plus AR pathway inhibitors are the standard of care for low-volume metastatic hormone-sensitive prostate cancer. And studies suggest a clinical benefit defined as delay in starting ADT and delay in progression, although a lot of that progression was PSA progression, with metastasis-directed therapy without ADT. And as noted, careful patient selection and informed consent needs to be obtained in that context. Primary radiation to the prostate should be considered in these patients, and more studies are needed, especially now in the era of PET imaging. So thank you very much.